How's it going, guys? We have a pass level question for internal medicine surgery, family medicine for 2CK. If you're studying for step one, obviously you're going to have to ace the 2CK, so this is high value for you. Some of you who see this question instantaneously will say, Mike, that question you made was too easy. Great. Okay, I mean, yes, this is pass level, as I just fucking said. So this is about yieldness. Okay, not everything I do has to be a tricky or obscure curveball. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at mehlman_medical, mehl_medical. The link is down below. Find me on Telegram. Links to the Telegram group and channel are down below. And I start the clips. A 52-year-old woman. She has worsening pain in her legs with exertion for the past 6 months. No history of trauma. Blood pressure is 140/90. She smokes 1 pack of cigarettes daily for 20 years. BMI is 35. She has loss of hair over the lower legs bilaterally. Question wants to know the most appropriate next step in diagnosis. So let's just whip through the answer choices here. Go backwards. Choice C, venous plethysmography. Wrong fucking answer. Never seen this as a correct answer. I've seen it as a distractor in a few 2CK nbme questions. In theory, this is some test that relates to electrical impedance of the veins, and somehow that can correspond to degree of occlusion. As I said, never seen as a correct answer. In this case, wrong fucking answer. Choice D, venous duplex ultrasound, wrong answer. Albeit an exceedingly high yield diagnosis for venous disease, which this is not. This is arterial disease. So if they want venous disease, they're going to tell you the patient often has hyperpigmentation of the lower limbs. That's hemosiderin deposition. Okay, so you have venous stasis, increased venous pooling, increased hydrostatic pressure in the veins. That can lead to transitation and small degree of hemosiderin deposition, okay? And that's also known as stasis dermatitis. And you need to know the term post-phlebitic syndrome, not phlebitic, okay? Post-phlebitic syndrome is an answer on one of the 2CK nbmes for the appearance that a patient has in venous disease, okay? Stasis dermatitis, post-phlebitic syndrome. They can say brawny edema. I've seen that in vignettes for venous disease. And you need to know venous ulcers are classically around the malleoli or medial malleolus, so it would be large, slothy, irregular ulcers, okay? And venous disease is a broad umbrella term where the patient can have varicose veins, okay, overt varicosities that are visible, but venous disease need not be varicose veins. You can just have, as I just described, venous disease where a patient has brawny edema, okay, hyperpigmentation, and the next best step would be venous duplex ultrasonography. And if that shows occlusion, we do compression stockings as the first step in treatment, okay? Compression stockings, very high yield. Be careful though, because if a patient has an active superficial thrombophlebitis, you're going to do subcutaneous enoxaparin, heparin, not compression stockings. Be careful. If they say there's a painful, palpable cord, a painful 1 centimeter palpable cord at the ankle, that may or may not track up to the knee, that's superficial thrombophlebitis, essentially just a DVT, but of a superficial vein, okay? So the same way you'd give heparin, subcutaneous enoxaparin for a DVT, well, you're gonna do that for a superficial thrombophlebitis, not compression stockings. But I would say 4 out of 5 questions as the next best step after you do the venous duplex ultrasonography, you're gonna do compression stockings. In this case, wrong fucking answer. Choice C, arteriography, wrong answer. And we want to be very careful with this, okay, because it's an appealing diagnostic modality. I've notably seen this as a wrong answer on the nbme exams for arterial disease, okay? I'll explain arterial disease in a second as we move through this question, but it's something I've mentioned in my PDFs that could be done in theory, because if we wanted to be more conclusive if we wanted to confirm the diagnosis of peripheral arterial disease, we would in theory do an arteriography, okay, to confirm the diagnosis. But it's almost always a wrong answer because USMLE likes next best step for peripheral vascular disease. So let's just continue moving through. Arterial calcium score, wrong answer. I've never seen this on any nbme assessment, but in theory this is done for coronary artery disease, okay? So coronary plaques can calcify. In general, atherosclerotic plaques can calcify. I've seen one step 1 question where they give a patient with stable angina, they ask what kind of vascular pathology you would visualize. The answer is 80% occlusion with calcified plaque, okay? It's the only time I've ever seen it, but this test I've never seen on an nbme exam. But arterial calcium score relates to the coronary arteries. Increased score is poor prognosis. In this case, wrong fucking answer. Choice A, ankle brachial indices, ABI is the correct answer. Exceedingly high yield diagnosis, as I prefaced with. Okay, some students instantly know the answer. That's great because this is important. So this is arterial disease. Okay, patient clearly has intermittent claudication. This is due to atherosclerosis. Risk factors being hypertension and cigarette smoking. Cigarette smoking is more important than hypertension for atherosclerotic development. Obviously, both important, but hypertension is eclipsed by smoking. They asked that in one of the 2CK nbmes. Diabetes is the worst risk factor for atherosclerosis. I don't want to get too tangential, but loss of hair over the lower legs bilaterally, this refers to trophic changes. Okay, you can get shiny, glabrous, hairless skin. Okay, whereas I already described the venous disease, hyperpigmentation, brawny edema, but arterial disease, you're going to get shiny, hairless skin, and you can get punched out ulcers distally, tops of the feet, bottoms of the feet, on the toes. They're small ulcers, whereas the venous ulcers, as I described, are large and slothy around the malleoli. Okay, so the first step in our for the diagnosis of arterial disease, the ABIs. So this should be around 1. We are comparing the ratio, or it's the ratio of the blood pressure in the ankle compared to the arm. So if you have atherosclerosis in your legs, you have peripheral vascular disease, you should have lower blood pressure in the ankle compared to the arm. So under 0.9 for this ratio is consistent with peripheral vascular disease, okay? If it's up over 1.10, that can reflect Monkberg arteriolosclerosis, which is calcification. Never seen it show up, but students have asked me about it, okay? So I just quickly mention it. But under 0.9, that's going to be peripheral vascular disease. So if they mention that in the last line of the question, they say ABIs are performed and show 0.6, well, the next best step in management, if it's listed, is going to be an exercise stress test. Okay, you want to determine the patient's exercise tolerance. If it's not listed, you're going to choose recommend a walking or exercise program. That sequence, very fucking important for 2CK, all right? Hear me out on that. So in about 50% of questions, they're going to want exercise stress test to determine exercise tolerance, as I just fucking said. Then you're going to do recommend walking or exercise program. Sometimes they don't even mention the stress test. They just want recommend a walking exercise program, all right? Now, why am I harping on this right now? Is some students jump to silostazole, a phosphodiesterase inhibitor, which is a wrong fucking answer almost always, okay? If they force you to choose a medication, A through E, all medications, and they want to know what you give in peripheral vascular disease, yes, you can give silostazole, okay? But don't choose it as first line. You're going to do stress test first. So after the ABIs, under 0.9, you're going to do stress test first. If it's not listed, you're going to do recommend walking exercise program. And if the latter demonstrates marginal efficacy in a patient, then you can add silostazole, phosphodiesterase inhibitor on top. You know the deal. To make more content, if you like my stuff, subscribe to my channel. And I appreciate your time. That's it.